Hello, sir.
Madam, will you proceed, please?
Yes, sir. Okay. Hello, everyone. Welcome to Tawhid Foundation for Allied Healthcare Sciences, Bangalore. Today's class is about systemic bacteriology part 3, which is gram-negative bacteria. So we'll start with Neisseria. Neisseria species are small gram-negative diplococci that classically look like paired kidney beans. A useful quick lab test is the oxidase test. Neisseria are oxidase positive, which helps separate them from many anterior bacteriae. They are fastidious organisms. They grow best at body temperature around 35 to 37 degrees Celsius in a humid carbon dioxide enriched atmosphere, which is why clinical labs often incubate them with 5 to 10% carbon dioxide. For culture, we use chocolate agar, which provides the heat release nutrients, which is X and Y factors needed by related organisms. Clinically, the two species to remember are Neisseria gonorrhea and Neisseria meningitis. Finally, their outer membrane contains lipo-oligosaccharide, which is known as LOS, an endotoxin that triggers inflammation and is central to many diseases symptoms, particularly in gonococcal infections. Neisseria gonorrhea. Here, structural features will explain pathogenesis and immune evasions. Neisseria gonorrhea does not have polysaccharide capsules, which contrast with Neisseria meningitis. This particularly explains difference in invasive potential. A major virulence and epidemiologic feature is the pilus. Here, as you can see, pilus, the hair-like projections used for attachment. The pilus protein is antigenic and varies a lot. There are over 100 serotypes, which is why immunity after infection is poor and reinfections are very common. So, in the outer membrane, there are three major proteins labeled first, second, and third. Protein 2, also called as OPA or porine variants in some, so it is involved in tight attachment to host cells and can vary antigenically. Again, hindering lasting immunity, these variations make vaccine development and long-term immune protection difficult. So, Neisseria gonorrhea infects only humans. There is no animal reservoir. So, transmission is mainly person to person. The organism is fragile outside the body. It's sensitive to drying and cooler temperatures, which is why which is genital contact, is the principal transmission route. During delivery, an infected mother can transmit the organism to her newborn, causing ophthalmia neonatum. So, although often think of genital infection, anorectal and pharyngeal colonization are clinically important reservoirs and can be asymptomatic, which complicates control effects. Virulence factor. Focus on three virulence main features. First is pili. These are the organism's primary adhesin. They attach to mucosal epithelial cell and also help resist phagocytosis. Strains with pili are usually virulent. Non-pileated strains are often avirulent. Second is endotoxin, which is lipo-oligosaccharide, LOS. In the outer membrane, it produces inflammation and contributes to many symptoms of gonococcal diseases. Third is IgA protease. The organism secretes enzyme that cleaves secretory IgA in mucosal secretions. By destroying IgA, the bacterium evades mucosal immune defenses and adherence more effectively. So, together, these factors explain how the organism attaches, invades mucosa, and causes local inflammation. Next is Neisseria gonorrhea pathogenesis. Preferentially, it attaches to and infects mucosal surfaces like urethra, vagina, cervix, rectum, pharynx, and conjunctiva. While many infections stay localized, dissemination can occur when bacteria enter the bloodstream, that is gonococcal bacteremia, seeding joints and skin. Clinically, men are more likely to show symptomatic urethritis, which is painful urination and plurulent discharge, whereas many women are asymptomatic or have mild symptoms, which is why, if it is untreated, female infections may silently ascend into the upper reproductive tract. Emphasize to the audience, asymptomatic carriage in women is a major public health problem because it enables silent transmission and later complications in women. In men, the classic presentation is acute urethritis. After an incubation of about 2 to 5 days, they develop dysuria, which is painful urination, and a thick fluent urethral discharge. This is usually very noticeable and drives men to seek care. Complications of untreated infections include epididymitis, which presents with scrotal pain and swelling and can threaten fertility if severe or recurrent. When presenting these points, you can pause and stress that the short incubation and over discharge are distinguishing clinical clues for gonorrhea in men. Next is, in women, the primary site is the endocervix, where the organisms cause cervicitis, which is a sign are plurulent vaginal discharge and sometimes spotting or intermenstrual bleeding. Because the infection can be mild or asymptomatic, it often goes untreated and ascends into the upper genital tract. The most important complication is pelvic inflammatory disease, which is PID, particularly inflammation of the urine tubes, salpingitis. PID can cause scarring of the fallopian tubes, which is the major pathway to infertility and ectopic pregnancy. Stress to students: preventing and promptly treating cervicitis reduces the risk of long-term reproductive harm. Next is again pathogenesis and clinical features. So, newborn delivered through an infected birth canal are at risk of ophthalmia neonatum, a severe purulent conjunctivitis caused by gonococcus. This can threaten vision if untreated. Historically, this led to routine prophylaxis of newborn eyes. In adults, auto inoculation from genital to eye or spread during sexual practices can also cause gonococcal conjunctivitis, which presents with a rapid onset of dense plurulent discharge and local inflammation. Emphasize the urgency: ophthalmia neonatum must be treated promptly to prevent corneal damage. So, for diagnosis, collect the correct specimen, which is urethral exudate in symptomatic men, and endocervical swab. Here, as you can see in women, on gram state, a rapid clue is saying gram-negative diplococci inside neutrophils. That's highly suggestive of gonorrhea, particularly in symptomatic men. For cultures, lab use Thyr Martin, which is selective chocolate agar medium, which contains supplemented with antibiotics, which is vancomycin to inhibit gram positives, colistin to inhibit many gram negatives. So this selective medium suppresses normal flora and allows isolation of Neisseria. It is NAAT, which is nucleic acid amplification test, are commonly used in many labs because they are highly sensitive and can be done on non-invasive specimens. Management centers on effective antibiotics and public health measures. Ceftriaxone, this is currently the treatment of choice. Highly recommendable single dose injectable therapy for uncomplicated gonorrhea in many guidelines because of rising resistance to other agents. Prevention: use protective measures, prompt treatment of symptomatic patients and their intercourse, gonococcal conjunctivitis in newborns, erythromycin ointment. Next is Neisseria meningitis. Now we'll shift to Neisseria meningitis, before was Neisseria gonorrhea. So it is a strictly human pathogen and spreads via airborne respiratory droplets. Many people, about 5% of people, carry it harmlessly in their nasopharynx. These carriers can spread infection from the nasopharynx. The bacteria may enter the bloodstream and then reach the meningitis or other organs, causing meningococcal disease, which is nothing but sepsis, arthritis, meningitis. Remember, asymptomatic carriage is common and important for transmission. Human is the only reservoir, and droplets spread around 5% of healthy carriers. Meningococcus is a leading cause. So, meningococcus is a leading cause of bacterial meningitis, ranking just after streptococcus pneumonia overall, but it is the most common in children, adolescent, and young adults, which is of 12 to 18 years. This age association is key. Often outbreak occurs in school, colleges, and military camps. So age group between 2 to 18 years give rise to meningococcus infection, and older adults pneumococcus. Virulence factor: polysaccharide capsule, it is antiphagocytic. Basis for serogrouping, which is A, B, C, W135, X, and Y. So here, the capsule is the most important virulence factor. It prevents phagocytosis and determines these serogroups, which is of 6 types. LOS, which is LOS endotoxin drives fever and shock, and IgA protein, LOS which is endotoxin, third is IgA protein. It helps the organism colonize the nasopharyngeal mucosa. Factor H binding protein blocks complement deposition, which is C3b. It helps survival in the bloodstream. So capsule, it will target vaccine serogroups, these important serogroups. So serogroup, next is clinical findings. Meningococcus cause two major syndrome. First is meningococcemia, which means sepsis, rash, and shock, and meningitis. Patients typically present with sudden fever, severe headache, neck stiffness. So CSF shows neutrophilic pleocytosis. Rapid progression is classic in meningococcemia. It looks for petechial or purpuric rash and shock. So these two most important manifestation of disease, meningococcemia and meningitis. Bacteremia, it also result in the seeding of many organisms, especially in meninges. These symptoms of meningococcal meningitis are those of bacterial meningitis: fever, headache, all this stiff neck, and an increased level of PMNS in the spinal fluid. Laboratory diagnosis. Diagnosis starts with gram stain of CSF or blood specimen. Look for intracellular gram-negative diplococci in the specimen sample which is given. Thyr-Martin chocolate agar is used for culture. Rapid antigen or PCR tests are available, but gram and culture remain classic exams for investigating this infection. Next is Haemophilus. Treatment and prevention for this Neisseria meningitis. Treatment include with high dose ceftriaxone or penicillin G if susceptibility is known. Prophylaxis for close contracts, rifampin, sometimes ciprofloxacin or ceftriaxone will be given, and then vaccines will give to patients conjugate polysaccharide vaccine against major serogroups. Next is Haemophilus. Haemophilus are small pleomorphic gram-negative rods on human mucosa. They need special growth factors, which is hemin, X factors, which is known as hemin, and V factor, which is known as NAD. These are released when blood is heated. So we culture on chocolate agar. The lipopolysaccharide act as an endotoxin. Haemophilus influenza is a small gram-negative coccobacillus. So here, this pathogen is human only and spread by droplets. Most serious infections were in kids 6 months to 6 years before vaccination. Key virulence factors include capsules, endotoxin, and IgA protease. These are the 6 species: Haemophilus influenza, Egypticus, Ducreyi, parainfluenza, Hemolyticus, and parahemolyticus. These are the primary diseases caused by this Haemophilus species. Pneumonia, sinusitis, otitis, meningitis, epiglottis, cellulitis, and bacteremia will be caused by Haemophilus influenza. Conjunctivitis caused due to Haemophilus aegypticus. Cancroid is caused due to Haemophilus ducreyi. Bacteremia, endocarditis, and several opportunistic infection is caused because of Haemophilus influenza, parainfluenza. All these two opportunistic infection can be caused by Haemophilus hemolyticus and parahemolyticus. So as I mentioned earlier, Haemophilus, it is small pleomorphic gram-negative cocci with a polysaccharide capsule present. It is one of the 3 important encapsulated pathogens along with pneumococcus and meningococcus. Serological typing is based on their antigenicity of capsule polysaccharide. There are 6 serotypes present, A till F. Type B is the most common one. Type B, it is used to cause most of the severe invasive disease such as meningitis and sepsis. Pathogenesis and epidemiology. This pathogen is, as I mentioned, humans only and spread by droplets. Most serious infections were in small children. It infects only human, no animal reservoir, and enter the body by the inhalation of airborne droplets. Mostly children will get infected at the age of 6 months to 6 years, with the peak age group between these 6 months to 1 year. Virulence factors, capsules, and endotoxin. These are the 3 major virulence factors of Haemophilus influenza: capsule, endotoxin, and IgA protease. It will degrade secretory IgA. It facilitate attachment to respiratory mucosa. Clinical diseases. Classic severe diseases, which is meningitis, epiglottis. Epiglottis is nothing but life-threatening airway swelling, cellulitis, sepsis, and septic arthritis. It is also common cause of otitis media and sinusitis. Remember, post-vaccine invasive HIV has dropped, but non-typable strains still cause ear and sinus infections. Laboratory diagnosis. To diagnose Haemophilus influenza, specimen include blood or cerebrospinal fluid, which is CSF. In invasive diseases, the organism does not grow on plain blood agar, but it grows on chocolate agar, which supplies both required factors, which is hemin, X-hemin, and VNAD. A classic lab test is the sterile phenomenon. Haemophilus influenza colonies grow near Azores on blood agar because Staph releases this NAD. As you can see here in this picture, drug resistance. This is test positive of Haemophilus influenza. As you can see, area without visible and area with visible growth. This is the blood agar. So treatment and prevention. Ceftriaxone is the drug of choice for serious invasive infection like meningitis. For localized infection, which is otitis media and sinusitis, options include amoxicillin, clavulanate, or trimethoprim. So these drug of choice will be given. Prevention. HIV vaccine is a conjugate vaccine, the type B capsular polysaccharide linked to diphtheria. So it is given in infancy and has drastically reduced cases of meningitis worldwide. Next is Bordetella, which means a whooping cough, pertussis. The Bordetella genus include very small aerobic gram-negative coccobacilli. The most important is Bordetella pertussis, which causes whooping cough. Others include B. paraptusis, which is milder pertussis like illness, bronchoseptica, which is animal infection. Sometimes it will also cause infection to humans, and B. Holmesi, which is rare sepsis. These B. Holmesis. Transmission and epidemiology. Pertussis spreads via airborne droplets during coughing, feeds. There's no animal reservoir, only humans. It is highly contagious, especially in infants and young children. Vaccination has greatly reduced incidence, but outbreaks still occur, often involving unvaccinated children or waning immunity in adolescents or adults. So the organism attaches to the ciliated epithelial cells of the respiratory tract but does not invade deeper tissues. Attachment is mediated by surface protein, which is paractin. This paractin, filamentous, and hemagglutinin and fumarae. This firm attachment is essential for disease. It allows the bacteria to remain in the airway, resist clearance, and secrete these toxins. Persistent toxin is a classic A-B endotoxin. The B subunit binds the receptor. The A subunit, these A and B subunits, so the A subunit enters cells and activates adenylate cyclase, raising CAMP. This leads to mucosal edema and contributes to the paroxysmal cough. It also causes striking lymphocytosis in blood by preventing lymphocytes from migrating into lymphoid tissues. So this lymphocytosis is a diagnostic clue. Pathogenesis and immunity. So this adenylate cyclase, it is a toxin which impairs neutrophil and macrophage killing. Next is tracheal cyclotoxin, a fragment of peptidoglycan that kills ciliated cells. And then next is epithelial cells. These epithelial cells, so here it will helps to recover from whooping cough, which is followed by immunity, which is lifelong. Second infection may occur, but usually milder. Reinfections occurring years later in adults, but it will be severe. So probable that the first defense against this infection is the antibody that prevents attachment of the bacteria to the cilia of respiratory epithelium. Antibodies to this are highly immunogenic. Clinical findings. So after 7 to 10 days, this pertussis has three stages. The catarrhal stage, first, which is catarrhal stage, about a week incubation, the patients look like they just have a common cold, running nose, mild cough, sneezing, low fever. Importantly, this is when bacterial numbers are highest. So patients are more contagious, but because symptoms are mild, the disease often goes unrecognized. Next is parasomial. So here, after 1 to 2 weeks, the parozymal stage begins. Ciliated cells are gone. Mucus clearance is impaired. The patient has repeated coughing fits followed by a characteristic inspiratory whoop as they struggle to inhale. So paroxysms often ends in vomiting and exhaustion. This stage last week's marked lymphocytosis in blood, which is common. This is the classic clinical features of this whooping cough. Next is Bordetella pertussis clinical findings. So after several weeks of intense coughing, patients enter the convalescent stage. Here it gradually becomes less frequent and less severe, but cough can persist for weeks. During this recovery period, airway damage and mucostasis predispose to secondary bacterial infections such as pneumonia. Stress to the audience that even though symptoms improve, the patient is still vulnerable to complications. So as you can see in this table, duration of the infection for incubation is 7 to 10 days. In 1 or 2 weeks, these are the symptoms. For 2 to 4 weeks, these symptoms will include. And last third stage, these symptoms will include. So this is a whole clinical presentation of Bordetella pertussis diseases. Laboratory diagnosis: collect a nasopharyngeal swab. This nasopharyngeal swab, not throat swab. It is done early during the cathedral or early parasomal stage for culture. The classic medium is boarded gango agar, which is potato glycerol blood. Because B. pertussis is delicate and slow growing, PCR is now preferred for rapid sensitive detection in prolonged cough. When cultures are negative, serology can help. Treatment, control, and prevention. Treatment is largely supportive. Oxygen fluid, suctionating secretions, antibiotics help if given early by shortening illness and reducing infectivity. Once severe, this coughing is established, antibiotics don't reverse damage but still reduce the spreading of infection. Azithromycin is best tolerated especially in infants. So the current vaccine is acellular pertussis, contains inactivated pertussis toxin plus adhesins. Pediatric schedules for children's around 4 to 6 years. Adolescents get booster at around 11 to 12 years and adults every 10 years or during pregnancy to protect newborns, infants. So the older vaccine was whole cell killed B. pertussis. It was effective but had more side effect. Many countries have switched entirely to acellular vaccines, but some developing regions still use whole cell because it's cheaper and may give longer immunity. So there is two vaccines. First, this one acellular vaccine and kill vaccine. It is contain inactivated B. pertussis organisms and various side effects, including post-vaccine at a rate of about 1 case per million doses administered. But still, it is in use in several countries, mainly countries which is developing. This azithromycin is the drug of choice for prevention of this disease in exposed or unimmunized individuals. Next is brucella. Brucella are tiny, non-motile, non-capsulated cocobacilli. They grow slowly and need enriched media. This laboratory diagnosis, it is oxidase positive, urease positive, and strictly aerobic, and they do not ferment carbohydrates. So there are 12 species with 4 species which is most commonly associated with human diseases. Brucella abortus, Brucella melitensis, Brucella suis, and Brucella canis. These are the 4 important species. The disease is caused by the member of Brucella, which is characterized by a number of names. Based on their original microbiologist who isolated and described this organism is Sir David Bruce, brucellosis, and Bernhard Bang disease. The clinical presentation is undulant fever, and the sites of recognized outbreak is Malta fever, Remington fever, rock fever, country fever. These are the outbreaks recognized site of the infection. Next is physiology and its structure. Brucella does not make exotoxin. Its key trick is being an intracellular parasite. After entry, it's phagocytosed by macrophages but prevent phagosome-lysosome fusion. So it is very small in size and non-motile, 0.5 to 0.6 to 1.5 μm, and it is non-motile, non-capsulated, and gram-negative cocci. It has slow growth, oxidase and urease positive, and generally require complex growth media. and it is strictly anaerobic and it does not ferment carbohydrates. Pathogenesis and immunity. So this brucella does not produce a detectable exotoxin. It is being an intracellular parasite. After entry, it's phagocytosed by macrophage but prevents this phagosome-lysosome fusion. After initial exposure, the organism are phagocytized by these macrophages and monocyte in which the bacteria will survive and replicate. These bacteria are carried to the spleen, liver, bone marrow, lymph nodes, and kidney as well. And then the bacteria secrete proteins that induce granuloma formation in these organs. So, these intracellular nicae marks treatment harder and cause chronic diseases. Brucellosis is zoonotic and more common where animal vaccination, pasteurization is lacking. Humans get infected by direct contact with animal tissues, which is farmer, vets, or lab workers, ingestion of unpasteurized milk or cheese, inhalation, lab accidents, possible bioterrorism. So it is most virulent for humans. Transmission. Brucellosis in humans can be acquired through this direct contact with organism, ingestion, inhalation, and unpasteurized or filtered food. So exposure would most likely be by inhalation. Clinical diseases. After first to third weeks, patients develop fever, chill, sweats, fatigue, weakness. This classic sign is undulant fever, rising and failing patterns if it is untreated. Some infections become chronic with relapsing fevers, arthritis, and organ involvement because its intracellular relapses happens if therapy is untreated or incomplete. For brucellosis, the best sample is bone marrow. Highest yield on blood culture is the gold standard but slow. Colonies may take up to 3 weeks or 2 weeks and need enriched media. Because culture is slow and hazardous, we often rely on serology. The standard agglutination test is widely used. A high or rising titer confirms infection. PCR is increasingly used for rapid detection. Because brucella lives inside macrophages, we need antibiotics that penetrate this cell. The standard is doxycycline plus rifampin for at least 6 weeks. For severe cases and aminoglycoside, short or incomplete therapy leads to relapse, so prolonged treatment is essential. There's no human vaccine for this brucella. Next is Enterobacteriaceae. It is a large family of E. coli, Salmonella, Shigella, Klebsiella, Proteus, Enterobacter, Serratia, and Yersinia. It is gram-negative rods, facultative anaerobes, ferment glucose. It is oxidase negative and reduce nitrites. So, these bacteria are classified. General properties of these bacteria include members of the family of this non-swarming gram-negative rods that share a common antigen. All members will grow rapidly aerobically and anaerobically, facultative anaerobes as well, on a variety of non-selective media, which is blood agar, and selective media, which is McConkey agar. These enterobacteria have simple nutritional requirements, need ferment glucose, reduce nitrate, and these are catalase positive and oxidase negative. These polysaccharides are common to all Enterobacteriaceae species. Common medically important species include Citrobacter, Enterobacter, E. coli, Klebsiella pneumonia, Morganella morgani, Proteus mirabilis, Salmonella, Salmonella serotype typhi, and non-typhoidal serotypes, Serratia, Shigella, and Yersinia. We'll start with E. coli. So E. coli is a gram-negative bacillus that is normally part of the human intestinal flora. It is a commensal organism, but also an important pathogen. As a commensal, it helps maintain gut health and completes with harmful bacteria. As a pathogen, it can cause watery diarrhea, which is enterotoxigenic types, bloody diarrhea, which is hemorrhagic types, and extra-intestinal infections such as UTI, urinary tract infection, sepsis, and neonatal meningitis. E. coli as commensal, it is the most abundant facultative anaerobes in the colon and feces, but it is outnumbered by obligate anaerobes like bacteroids. As a pathogen, it is the most common gram-negative bacillus isolated in sepsis. It is responsible for less than 80% of community-acquired UTIs and many hospital-acquired infections. Major cause of gastroenteritis, which is food and waterborne. Important in neonatal meningitis due to capsule antigen. Its properties, morphology, straight gram-negative rods, metabolism, facultative, anaerobe, ferments glucose and lactose. It is oxidase negative. Antigenic structures include O antigen, which is cell-wall antigen, H antigen, which is flagellal antigen, and K antigen, which is capsular antigen. So with less than 150 O and 50H and 90K types, E. coli has over 1,000 antigenic types, explaining its variability. Pathogenesis, large numbers normally live in the intestine. Most infectives are endogenous from patient's own flora, example, UTI, after trauma or catheter, transmission of diarrheal E. coli, ingestion of contaminated food or water, reservoir for E. coli, cattle, infection usually via undercooked beef and hamburgers. Next is, so E. coli causing gastroenteritis are divided into 5 main groups. ETEC, which is enterotoxigenic, EPEC, which is enteropathogenic, EAEC, which is enteroaggressive, EHEC, which is enterohemorrhagic, also called as STEC, and last is EIEC, which is enteroinvasive. So these ETEC, EPEC, and EAEC, this mainly affects small intestine, secretory, diarrhea, and EHEC and EIEC, these two mainly affects large intestine, which is bloody diarrhea. E. coli virulence factor, pili femore helps attach to intestinal and urinary epithelium. Capsule K antigen, it protects from poly, it protects from phagocytosis. Endotoxin LPS, it causes fever, shock, hypotension, which is gram-negative sepsis. Endotoxin, it includes heat labile toxin, heat stable toxin, and Shiga toxins. These 3 toxins, heat labile, heat stable, and Shiga toxins. So we'll start with enterotoxin, which is heat labile toxin LT and heat stable ST toxin. LT toxin increases hypersecretion of water and electrolytes, which is watery diarrhea, and ST, it increases and same effect it will show. So together they can cause profuse watery diarrhea, especially in travelers. Next is Shiga toxin. Shiga toxin removes adenine from 28S RNA and inhibits protein synthesis, which result to cell death, results in bloody diarrhea carried by lysogenic bacteriophage. Verotoxin, it is another name of toxin which kills vero cells in culture. Infective dose is very low, less than 100 organism. It can cause hemolytic uremic syndrome, which is nothing but renal failure, anemia, and thrombocytopenia. So this thrombocytopenia. Next is other clinical findings. Urinary tract infection, which is cystis, bladder, or pleonephritis kidney, neonatal meningitis, especially due to capsular antigenic strain, and sepsis, most common gram-negative bacillus in bloodstream infections. E. coli ferments lactose, producing pink colonies on McConkey agar. So this helps distinguish it from non-lactose fermenters like Salmonella or Shigella. This biochemical tests include it produces indole from tryptophan, Decarboxylates lysine uses acetate as the only carbon source and it is motile. So special test E. coli, this O157 is to H7 EHEC strain. It does not ferment sorbitol while other E. coli strains will do, and it is used as a diagnostic markers. Treatment and prevention. Treatment depends on the disease type. UTIs, methoprim, sulfamethoxyl, and ciprofloxacin will be given for UTI infection, sepsis and meningitis, third generation cephalosporins, and diarrheal infections. It will give usually supportive care plus rehydration. Antibiotics are not routinely used, especially for EHEC, because killing bacteria release more sugar toxin, which will result to risk of these infections. Prevention, safe water supply and proper sewage disposal, proper cooking of beef, and general hygiene in handling food. Next is salmonella. Salmonella are gram-negative rods, which is motile flagella is present, and it do not ferment lactose unlike E. coli. It will produce H2S gas, which blackens colonies on media like TSI agar. Antigenic structures, O antigens, which is cell wall, LPS, H antigen, which is flagellar protein, and VI antigen, which is capsular antigen, especially in S. typhi, important for virulence. As you can see, the microscopic image of Salmonella typhi gram stain. So, O antigen, it is heat stable polysaccharide used for grouping Salmonella into serogroups. H antigens, flagellar protein, two forms, phase 1 and phase 2. Only one expressed at a time helps immune invasion. VI antigen, capsular polysaccharide antigen found in S. typhi. It prevents phagocytosis and used for serotyping S. typhi. Next is there are three different classification systems. So Ewing system, three species, S. typhi, S. choleraeosis, and S. enteritis. Next is Kaufman and White system. Every serotype given a separate species name, which is around 1500 species. Example is Salmonella Dublin. And third one is DNA hybridization system. So modern view, S. typhi is not a separate species but a serotype of S. enterica. Currently we use Salmonella enterica serotype typhi, which is nothing but S. typhi. Clinical diagnosis. Clinically, Salmonella are grouped into typhoidal species and non-typhoidal species. So for typhoidal species, it can cause enteric fever, example S. typhi and S. paratyphi. For non-typhoidal species, it causes gastroenteritis, which is enterocolitis, and sometimes metastatic infection like osteomyelitis. This osteomyelitis. So example S. enterica serotype, cholera, choleriasis often cause metastatic infections. Epidemiology and transmission. It is spread by ingestion of contaminated food or water. Human source is only S. typhi is exclusive to humans. Infections can come from carriers, especially chronic gallbladders, which carries who shed bacteria in feces. Animal sources, other salmonella have animal reservoirs. Carriers, for example, poultry eggs, undercooked meat, pets, which is turtle, snake, lizard, can also transmit salmonella. It is caused by non-typhoidal strain, which pathogenesis invade epithelial and subepithelial tissue of a small and large intestine. So here incubation period, it will last 12 to 48 hours after injection. Clinical features will include nausea, vomiting, abdominal pain. So it is caused by this S. typhi and paratyphi of A, B, and C. Infection begins in the small intestine, but only few gastrointestinal symptoms will occur, this organism will enter and multiply in this mononuclear phagocytes and then spread to the phagocytes of liver, gallbladder, and spleen, which will lead to bacteremia. Salmonella can also grow and survive within phagosomes in phagocytosis. Invasion of this gallbladder will result in establishment of carrier state and excretion of bacteria in feces for longer period. So about 3% of this typhoid fever patients will become chronic carriers. Septicemia, it is most often caused by Salmonella choleraeosis, accounts for about 5 to 10% of salmonella infection. Patient with this underlying chronic disease such as sickle cell anemia or cancer, or a child with enterocolitis, it will result in the seeding of many organs with osteomyelitis, pneumonia, and meningitis, which is the more common sequel. So the symptoms will begin with fever but little or no enterocolitis. This laboratory diagnosis include enterocolitis, which is stool culture, enteric fevers, blood culturing, bone marrow cultures, stool cultures on McConkey agar media, TSI media. So in McConkey agar media, it is non-lactose fermenting. Colorless colonies will be grown, and on TSI agar, an alkaline slant and an acid, but frequently with both H2S black color in the bud will be seen. S. typhi, it does not form gas and produces only a small amount of H2S. Treatment Treatment include enterocolitis, usually a self-limited disease which resolves without treatment only. Fluid and electrolyte replacement may be required. The treatment of choice for enteric fever such as typhoid fever and septicemia with metastatic infection is either this ciprofloxacin or ceftriaxone drug of choice. Ampicillin or ciprofloxacin should be used in patients who are chronic carrier of Salmonella typhi. Properties Properties, they are non-lactose fermenting gram-negative rods. It is distinguished from Salmonella by three criteria. They'll produce no gas from the fermentation of glucose. They do not produce H2S and they are non-motile. So all Shigella have O antigen in their cell walls and it is used to divide the genus into four groups, which is nothing but A, B, C and D. So four species consisting of almost 50 O antigen based on serogroups. These species of Shigella, dysentery, flexneri, boydii, and sony, epidemiology and transmission. So shigellosis is only a human disease. That means there is no animal reservoir included. Transmission is through fecal oral route and no prolonged carrier state with Shigella infection is seen. Pathogenesis, it will invade epithelial and subepithelial tissues of small and large infection. Incubation period include 12 to 14 hours after ingestions. Shigella cause almost exclusively in the gastrointestinal tract and produce bloody diarrhea, which is dysentery, by invading the cell of mucosa. Some strain produce enterotoxin, which is called as Shiga toxin. Shiga toxin is encoded by this lysogenic bacteriophages. So this incubation period, it will last up to 1 to 4 days. Symptoms, it begins with fever and abdominal cramps followed by diarrhea, which may be either watery at first, but later it contains blood or mucus as well in fecal. Young children and elderly are the most severely affected with this infection. Shigella dysentery causes the most severe diseases. So laboratory diagnosis, Shigella from non-lactose fermenting colorless colonies will be seen on McConkey agar media. Enteric typhoid fever blood culture is positive during the first week. On TSI agar, they cause alkaline slant and acid bud, but with no gas and H2O presence. Treatment include fluid and electrolyte replacement. In severe cases, drug of choice, ciprofloxacin and fluoroquinolone will be given to patients, and trimethoprim sulfamethoxyl is an alternative drug choice. Next is Klebsiella. Klebsiella, it is gram-negative rods, non-motile, distinguishes them from most other Enterobacteriaceae species. It is found in human mucosal surface, especially in GIT tract. It also exists in soil and water and have a large polysaccharide capsules which gives colonies a mucoid appearance, increase virulence by protecting against phagocytosis. As you can see, Klebsiella pneumonia on McConkey agar plate. So major concern is multi-drug resistance. Many strains resistance to beta-lactam antibiotics, even carbapenems, multiple other antibiotic classes. These hospital-acquired Klebsiella are very difficult to treat and a big challenge in clinical practice. Medically important species include Klebsiella pneumonia and Klebsiella oxytoca, which causes pneumonia, Klebsiella granulomatis, which causes granuloma, inguinal, which is donovanosis. Klebsiella pneumonia, it is found in the respiratory tract of almost 10% of healthy people. It causes pneumonia, especially in patients with weakened immunity. Pneumonia features include low blood pneumonia, necrotic destruction of alveoli, formation of cavities, and blood taint, which is current jelly sputum, a classic sign of this infection. Granuloma inguinal, which is donovanosis, it is caused by Klebsiella granulomatis. It is sexually transmitted after repeated exposure. After long incubation, around weeks or months, subcutaneous nodules form on genitia region. Nodules break down into painless granulomatous ulcer resembling syphilis. It is also called donovanosis. Old name is Donovania granulomatis. Laboratory diagnosis: gram stain, gram negative rods with capsule clear halo will be seen. Culture large and mucoid colonies will be visible. Treatment guided by sensitivity testing due to resistance. Often start empirically with aminoglycoside gentamicin plus cephalosporin, which is cefotaximine, until results is available. Next is protease. Protease, it is gram-negative facultative anaerobic rods. It produces enzymes such as phenylalanine deaminase and urease, splits urea NH2 plus carbon dioxide, which is alkanizes urine. It is very motile, showing swarming motility on blood agar, concentric waves, antigenic cross reactions. So certain O antigens react with rickettsial antigens, basis of Weil-Felix test. This Weil-Felix test. So important species of protease include Protease vulgaris and Protease mirabilis. This is the image of Protease species swarming motility on blood agar plate. As you can see, the arrow, it indicates this swarming motility on blood agar plate. Next is pathogenesis and epidemiology. Normal flora in human colon. It is also found in soil and water. Causes of UTI: more common in women, short urethra. Motility helps them ascend urinary tract. Urease activity raises urine pH and promotes formation of steroid stones, which is magnesium ammonium phosphate calculi. These stones block urine flow, damage epithelium, and harbor bacteria. So it reoccurrence UTIs infection. Laboratory diagnosis for culture shows characteristic swarming growth on blood agar, growth inhibited on phenyl ethyl alcohol agar, isolated colonies, non-lactose fermenters, colorless colonies on McConkey agar. TSI, this agar produces H2S, which is blackbird. Indole tests include P. mirabilis, indole negative, and P. vulgaris, indole positive. Treatment for Proteus mirabilis, it is usually sensitive to ampicillin. Protein vulgaris, treated with cephalosporins. Example is cefotaximine. Drug choice guided by antibiotic sensitivity testing. Next is Yersinia. So genus Yersinia, it is a small gram-negative rods, members of Enterobacteriaceae. Important human pathogens include Yersinia Pestis, Yersinia enterocolitica, and pseudotuberculosis. So these three are the important species of Yersinia: Pestis, enterocolitica, and pseudotuberculosis. So pathogenic Yersinia survive inside host cell by resisting phagocytosis. Use type 3 secretion system, which is T3SS, injects proteins into host cells. So these three species, Pestis is highly virulent pathogen that causes potentially fatal systemic disease, which is known as plague. Enterocolitica and pseudotuberculosis are primarily enteric pathogens that are relatively uncommon. Pathogenesis and immunity. So here, pathogenic Yersinia survive inside host cell by resisting phagocytosis. Use type 3 secretion system. This injects protein into host cell YOPH gene product. It inhibits phagocytosis by dephosphorylating proteins YOPE gene product. This cytotoxins disrupt actin filaments. And third one, it induces apoptosis of macrophages. Together, it will help bacteria survive and spread. Yersinia persists. So two virulence plasmids encode fraction 1 and plasminogen activator. So fraction 1 F1 antigen capsular protein phagocytic, and second is plasminogen. It degrades complement, block opsonization, and breaks down fibrin clots, and rapid bacterial spread will occur. So other virulence factors include serum resistance and special ion uptake mechanism, which is cytophore independent. All Yersinia infections are zoonotic. Humans, accidental host. Two epidemiological forms of Yersinia persist: urban plague and Sylvatic plague. Urban plague, rats are natural reservoir via it spreads via rat fleas, and Sylvatic plague, it is wild animals, squirrel, rabbit, field rat, cats, etc. act as a reservoir. Other species, yes, other species include Yersinia enterocolitica reservoirs such as pigs, rodent, livestock, and rabbits. And for pseudotuberculosis reservoir include rodents, wild animals, and game birds. Urban plague, rat, it will transfer to rat to flea and then human cycles. Flea gets infected while feeding on bacteremic rats, and inside flea, bacteria multiply and block the gut. Hungry flea bites human, which will regulate this bacteria into bite wound and causes rapid spread of plague in crowded areas. This sylvatic plague, it maintained in wild animal population, hard to eradicate. Transmission route is through flea bite, which is very most common, handling or eating infected animals. And next is human to human spread, which is rare, but except in pneumonic plague where respiratory droplets transmit infections. Clinical diseases, incubation is less than 7 days. Features include high fever, painful swollen lymph nodes, which will give rise to eczema, and without treatment, bacteremia develops quickly. Mortality is around 75%. So if it is untreated. Incubation period, it will last around 2 to 3 days. Rapid onset, fever, malaise, followed by severe pneumonia, highly contagious, spread via aerosol person to person, and if it is untreated, mortality is 90%. So enterocolitica causes enterocolitis. Incubation is around 1 to 10 days. Average is 4 to 6 days. Symptoms include diarrhea, fever, abdominal pain. Many mimic appendicitis due to mesenteric lymphadenitis. So pseudotuberculosis, it can cause similar enteric disease, which is less common. Laboratory diagnosis: smear and culture of blood, pus from buboes, fluorescent antibody staining, and serology, four-fold rise in antibody titer. Treatment include choice streptomycin plus tetracycline. Alternatives will be given chloramphenicol and gentamicin. Prevention: control rodent population and fleas. prophylactic antibiotics and exposed to person. Next is Pseudomonas aeruginosa. It is gram-negative rod aerobic motile single polar flagellum. It is an opportunistic pathogen which infects immunocompromised individuals, burn patients, cystic fibrosis patients, and those with indwelling catheters. It is found ubiquitously in water, soil, sinks, hospital sinks, and disinfectants. So disinfectants smell, it is grape-like odor in cultures. Some species produce diffusible pigments, which is pyocyanin, which is blue in color, pyoverdin, yellow-green, and pyorubin, reddish-brown. Pathogenesis and immunity. Here, adhesins, it is flagella, pili, and LPS, which is lipopolysaccharide alginate. Here, flagella and pili also mediate motility. Lipid A of LPS is responsible for endotoxin activity, and alginate is mucoid exopolysaccharide that forms a prominent capsule on bacterial surface, which will protect the organism from phagocytosis and antibiotic killing. Secreted toxins, exotoxin, it inhibits protein synthesis, which is nothing but tissue necrosis. Third, next is phospholipase C. It will damage cell membranes and it will damage cell membrane which is heat labile hemolysis and break down lipids and lecithin, which is facilitating tissue destruction. Exoenzymes include SNT, which are extracellular toxin produced by aeruginosa. Type 3 separation system introduces the proteins into their target eukaryotic cells, which will lead to epithelial cell damage and facilitate bacterial spread, tissue invasion, and necrosis. Epidemiology. Here, Pseudomonas is an opportunistic pathogen present in a variety of environments and has minimal nutritional requirement. It tolerates a wide range of temperatures, which is around 4 to 42 degrees Celsius, and it is resistant to many antibiotics and disinfectants. Patients at a higher risk for developing infections include neutropenic or immunocompromised patient, cystic fibrosis patient, burn patient, and individuals receiving broad spectrum of antibiotics. Clinical diseases, pulmonary infections, it include infections of lower GIT, asymptomatic colonization, inflammation, necrotizing bronchopneumonia, and colonization is seen in patients with CF, other chronic lung disease, and neutropenia. Other Pseudomonas infection, skin and soft tissue infection, infection of burn wounds, folliculitis, osteochondritis, UTI infections, ear and eye infections, bacteremia, and endocarditis. Treatment, prevention, and control. Antimicrobial therapy for Pseudomonas aeruginosa infection is frustrating because the bacteria are typically resistant and it is a combination of active antibiotics, so it is generally required for therapy to be successful in patients with serious infections. Laboratory diagnosis include growth microscopy, observation of thin gram-negative rods arranged in singly or in pairs suggestive of Pseudomonas. Cultures include rapidly growth and has flat colonies with spreading border. Beta hemolysis, a green pigmentation, cause the production of blue, which is pyocyanin, and yellow-green pyoverdin pigments. Characteristics of sweet grape-like odor will occur. Next is Vibrio. Vibrio, it is a gram-negative curved rods, comma shaped. It is motile single polar flagellum, facultative anaerobes. It is found in aquatic environments, especially brackish water and estuaries. Important human pathogens include Vibrio cholera, Vibrio parahemolyticus, and Vibrio vulnificus. So, this is the gram stain of Vibrio cholera microscopic image. It can grow on a variety of simple media within a broad temperature which ranges around 14 to 40 degrees Celsius. Its property, currently Vibrio, the genus, is composed of more than 200 plus species based on Subspecies, three species, which is particularly important, as I mentioned earlier: cholera, parahemolyticus, and vulnificus. All species of Vibrio require sodium chloride for their growth, and it can grow on moist media as well without additional salt. Most other halophilic, which is salt-loving species, require supplementation with sodium chloride. It will tolerate a wide range of pH, which will range around from 6.5 to 9 pH range, but are susceptible to stomach acid. Exposure to a large inoculum of organism is required for this disease. If acid gas production is reduced or neutralized, patients are more susceptible to Vibrio infections. Next is properties. Why it is not? So all strain possesses lipopolysaccharides consisting of lipid core polysaccharides and O polysaccharide chain. This O polysaccharide is used to subdivide Vibrio species into serogroups, and it has over 200 serogroups based on O antigen. Major pathogenic serogroups will be seen here. Vibrio parahemolyticus and vulnificus are marine organisms and live primarily in the ocean, especially in warm salt, and they are halophilic. That means they require a high sodium chloride concentration to grow. Parahemolyticus causes diarrhea associated with eating raw or improperly cooked seafood. Vibrio vulnificus causes cellulitis and sepsis, and cholera and parahemolyticus possesses two circular chromosomes. So, Vulnificus and non-O1 Vibrio cholera produce acidic polysaccharide capsule. It is important for disseminated infections not to produce a capsule infection with this organism, and it do not spread beyond the confines of the intestine. Vibrio cholera is divided into serogroups according to the nature of its O cell antigen. This Vibrio cholera O1 and O139 produce cholera toxin and are associated with epidemics of cholera. Other strains of Vibrio cholera generally do not produce cholera toxin and do not cause this epidemic diseases. Serogroups is further subdivided into serotypes, which is this and biotypes classicals of AI TER. So epidemiology and transmission. Transmission is through free living inhabitant of freshwater causing infection, which is only in human beings. Asymptomatic human carriers are believed to be of major reservoir and spread by consumption of contaminated water and food. Direct person to person spread is rare because infectious dose is very high. Most of the Vibrio cholera species are killed by stomach acid, but bacterial levels is contaminated through waters increasing during the warm months. So, cholera toxin secrete hyper secretion of electrolytes and water. Toxin co-regulated pilus, which is binding site, mediate adherence to intestinal mucosal cell, and accessory cholera exotoxin increases intestinal fluid secretion, and zonula occult toxin increases its intestinal permeability. So these are the virulence factors of Vibrio cholera. Cholera toxin encoded by bacteriophage. It is a complex A and B toxin. Subunits bind to the ganglioside receptors on intestinal epithelial cell, which enable the entry of A subunit. The internalized A subunit interact with G protein that control adenylate cyclase, which will lead to the catabolic conversion of adenosine triphosphate, which is nothing but ATP, to cycline adenosine monophosphate, which is CAMP, and this result in hypersecretion of water and electrolytes. Clinical features include symptoms of cholera due to the production of enterotoxin and gastrointestinal tract. Majority of individuals exposed to cholera show asymptomatic infection or diarrhea. Some individuals develop severe, rapidly fatal diarrhea, and clinical manifestation of cholera begin with an average 2 to 3 days of exposure to infection. It is characterized by abrupt onset of watery diarrhea and vomiting. Diarrhea is nothing but colorless and odorless, free of protein and speckled with mucus, rice water, stools. So clinical features continuation resulting severe fluid and electrolyte loss. It can lead to dehydration, painful muscle cramp, metabolic acidosis, and hypokalemia and hypovolemic shock with cardiac arrhythmia and renal failure. Mortality rate is as high as 70% if it is untreated in patients, but less than 1% in patients who are promptly treated with replacement of loss of fluids and electrolytes. Disease caused by Vibrio cholera can be severe as disease caused by Vibrio cholera O1. Other serotypes of cholera do not produce cholera toxin and are usually responsible for mild watery diarrhea. It can also cause extraintestinal infections such as septicemia, particularly in patients with liver disease or hematologic malignancies. Microscopy, laboratory diagnosis through microscopy. Vibrio species are very small. It ranges between zero point 0.5 till 3 μm. It is curved gram-negative rods. Direct microscopic examination of stool specimen can provide a rapid and presumptive diagnosis in cholera outbreak. Immunoassays detection of cholera toxin, and it is used for diagnosis of cholera in endemic areas. PCR, it is a rapid method to identify this infection and has high sensitivity compared with alternative tests. Culture sample will be given. Vibrio organism, it will survive poorly in acidic as well as dry environment. If culture is delayed, specimen should not be mixed in carry blade transport medium and refrigerated. Vibrios will grow because of this. So most media used in clinical laboratories include TCBS, which is nothing but thiosulfate citrate bile salt sucrose agar, specially selective agar for vibriosis, and alkaline peptone broth. pH ranges between 8.6. Enrichment broth. Treatment include fluid and electrolyte replacement, antibiotics, azithromycin, which is a very common drug reduced to bacterial burden and endotoxin production, as well as duration of diarrhea. Control and prevention, proper disposal and treatment of infected fecal waste produced by cholera victims. Contaminated material include example clothing and bedding. Antibacterial treatment of general sewage by chlorine, ozone, and UV light. Other decontaminated water by boiling, chlorination, whatever possible use can be done. Surveillance, prompt reporting allow for containing cholera epidemics rapidly. Next is Helicobacter. It is currently more than 40 species. It has gastric Helicobacters. The most important species is Helicobacter pylori. This Helicobacter species colonize the intestine and it is associated with gastroenteritis and bacteremia. Example, Helicobacteria cnidae and finale. It is isolated most commonly in patients having underlying health issues. So whole, it is gram negative, curved or spiral rod, microaerophilic, found mainly in the human stomach, strongly associated with chronic gastritis, peptic ulcer, and gastric adenocarcinoma. Its properties, it is gram-negative, spiral rod, highly motile, produce abundance of urease. Most of the species are catalase and oxidase positives. It will not ferment or oxidize carbohydrates. Helicobacter, it requires a complex medium supplemented with blood, serum, charcoal, starch, or egg yolk. So it is microaerophilic condition, decreased oxygen and increased carbon dioxide is required, and a temperature between 30 to 37 degrees Celsius helps to grow this bacteria. Epidemiology, infection are common particularly in people with low socioeconomic class, which is around 70 to 90%. Again, 70 to 90% of patients with gastric gastritis, ulcers, or duodenal ulcers infected with Helicobacter pylori. Humans are the primary reservoirs. Example is primates and pigs. Colonization is believed to persist for life unless the host is specifically treated. Transmission is most likely via the fecal oral route, that is person to person. Pathogenesis and immunity. Initial colonization is facilitated by a blockage of acid production by bacterial acid inhibitory protein, neutralization of gastric acid by ammonia, which is produced by bacterial urease activity. The activity motile helicobacter can then pass through gastric mucus if it is adhered to the gastric epithelial cell by multiple surface adhesion proteins. So, this localized tissue will damage mediated by urease byproducts. Urease converts urea ammonia to carbon dioxide, which neutralizes acid, protects bacteria. So this cytotoxin, after penetration into epithelial cell, will damage the cell by producing vacuoles. These genes injected into host cell epithelial cell by secretion system, which will then interfere with normal cytoskeletal structures of epithelial cell, and release of these proteases molecules by this neutrophil is believed to contribute to gastritic and gastric ulcers. This disease caused by Helicobacter is directly related to the site of colonization, which is acute gastritis characterized by feeling of fullness or nausea or vomiting. These are the symptoms. This can evolve into chronic gastritis, which is chronic gastritis. It may involve the entire stomach. 10 to 15% of patients will progress to develop peptic ulcers. Peptic ulcer will lead to gastric ulcers, duodenal ulcer, gastric adenocarcinoma, and then these positive strains will associated to lymphoid tissue, which is nothing but mild B-cell lymphomas. Laboratory diagnosis is through invasive test, microscopy, endoscopy plus biopsy. Pyroli is detected by histologic examination of gastric biopsy. Non-invasive tests include urea breath test, which is patient ingests labeled urea. Stool antigen test detect bacterial antigen in feces, and another is serology test, which is detect antibodies, which is less useful for eradication monitoring. So these are the laboratory tests. Treatment include triple therapy, first line, which is proton pump inhibitor, PPI. This proton pump inhibitor, clarithromycin, amoxicillin, quadruple therapy. Treatment goal, which is include eradicate infection, heal ulcer, prevent occurrence and malignancy. Next is Campylobacter. It is gram-negative, curved or spiral rods, microaerophilic, motile, which is polar flagella. Important human pathogens include Campylobacter jejuni and Campylobacter coli. Jejuni, it is most common cause of bacterial gastroenteritis worldwide, and coli similar but less frequent. Reservoirs is poultry, cattle, ships, and pets. This too is the important species. More than 50 species and subspecies are recognized, where 4 are recognized by human pathogens. These Campylobacter infections are zoonotic with a variety of animals serving as reservoir. This example include cattle, sheep, rodents, poultry, pigs, dogs, cats, etc. Infections are acquired by consumption of contaminated food, especially this poultry, milk or water. Person to person spread via fecal oral route, which is very rare. Virulence factor. So it is transmitted via fecal oral route, mainly through contaminated food. Invades intestinal epithelium, which will lead to inflammatory diarrhea. It produces cytotoxin and enterotoxin, which is nothing but diarrhea, cramps, sometimes fever. It may trigger post-infection complications, which is Guillain-Barré syndrome, which is GBS, reactive arthritis, which is the most common one. Laboratory diagnosis include this stool microscopy, which is gram staining. S-shaped gram-negative bacteria will be seen. Stool culture, these Jejuni coli and Eupacillensis require culture at 10% carbon dioxide, 42 degrees Celsius. Treatment include these drugs, erythromycin or azithromycin. Next is Burkholderia species. This Burkholderia cepacia complex, it is closely related to Pseudomonas species. It is complex It is complex species which contains plant pathogen that have arisen as opportunistic organism. It is usually associated with pneumonia in patients with cystic fibrosis or chronic granulomatous diseases. It causes endocarditis, pneumonitis, and urinary tract infection. Isolates are motile by means of polar tufts of flagella. So, key colony characteristics include well grown moist media but may lose viability on SBA in 3 to 4 days. Without transfer, it will grow nicely on Meconicae agar. It is a selective media which contain antimicrobials which are available to increase its recovery. This Burkholderia cepacia, it is a selective agar media. It contains culture medium of choice, Pseudomonas cepacica, agar also, and oxidative fermentative base, polymyxin B, bacitracin, lactose, and colonies will produce diffusible pigments appearing as yellow or green in color with rough and serrated edges. It shows non-wrinkled colonies which will trade to use to differentiate isolates from other species which also produce a yellow pigment, but Sepacica does not fluorescence like Aeruginosa. It can also produce a non-fluorescing yellow or green pigment which will diffuse into this media. For biochemical properties, it is weak, slow, positive oxidase reaction, oxidizes glucose, maltose, lactose, and mannitol. These lysine decarboxylase positive, and it will also show or ornithine decarboxylase, which is ODC negative, nitrate negative. Formally, it is called as Acinobacter malai. Only non-motile Burkholderia species will show this. It causes glanders, which is nothing but respiratory tract zoonosis, primarily affecting livestock such as horses, mules, and donkeys. It is rare in humans but can produce several local suppurative or acute pulmonary infection. It is considered by government agencies to be a potential bioterrorism agent. So coccoid, it is also in coccoid to rod shape, sometimes occurring on filaments or under special conditions with branching involutions. Key colony characteristic produces non-pigmented colonies in 2 days. On growth of McConkey agar is visible, and it may not grow on this BAP media and unable to grow at 42 degrees Celsius unlike other species. And this appears grayish white translucent colonies. Later, it will become yellow and opaque. Oxidase production is variable. Oxidase variable oxidizes glucose, nitrate positive, and arginine dihydrolyse. It is positive. It gives a positive Strauss reaction when a material containing virulent. This B. Burkholderia malai species was inoculated into peritoneal cavity of male guinea pigs. Scrotal swelling and tenderness and lesions will develop within 2 to 4 days after exposure with this Burkholderia species. So morphology is similar to Pseudomonas aeruginosa. It is multitrichous with a tuft of 3 or more flagella per pole. It causes melioidosis, which is a Vietnamese time bomb, and aggressive granulomatous pulmonary disease caused by ingestion, inhalation, or inoculation of these organisms. It is considered as the potential agent of bioterrorism. This organism should be considered especially when a non-formative wrinkle colony is isolated, which will demonstrate bipolar staining on gram stain smears. So summary of this gram-negative cocci and bacteria. First is E. coli, which is gram-negative rot, facultative anaerobes, normal gut flora. Pathotypes include EPEC, which shows a diarrhea in infants, ETEC, watery diarrhea. This other type of ETEC, bloody diarrhea, UPEC, urinary tract infections. Virulence factor include adhesine, toxins, Shiga toxin, capsules. Laboratory diagnosis on McConkey agar, TSI slant, and indole positive. Treatment includes supportive. Antibiotic is given if it is severe. Maintain hydration. Next is Salmonella. It is non-lactose fermenting, producing H2S. It is showing motile rot. Diseases include enterocolitis, which is self-limited, and typhoid fever, which is systemic. Laboratory diagnosis shows blood culture, stool culture, TSI agar, black bud gas. Serotyping shows OHNVI. Treatment include fluids, antibiotics for severe and systemic diseases. Third is Shigella. It is non-motile, non-lactose fermenter, only human pathogen. Show this. It causes bacillary dysentery, bloody mucoid diarrhea. Virulence is Shiga toxin, invasion of colonic mucosa. Laboratory diagnosis show stool culture, non-lactose fermenter, not absence of H2S, microscopic pus and RBCs. Treatment will be given rehydration plus antibiotics, ciprofloxacin. Next is Klebsiella. It is non-motile, large polysaccharide capsule. It shows mucoid colonies. It is an opportunistic pathogen. Pneumonia, which is current jelly sputum. UTIs, donovenosis. Laboratory diagnosis include gram stain, culture, treatment guided by sensitivity, antibiotic sensitivity due to multi-drug resistance. Next is Proteus. It is motile urease positive, which shows steroid stones, causes UTI infection, wound infection. Laboratory diagnosis include swarming motility, as I shown in McConkey agar plate. Non-lactose fermenter, H2S positive, indole test differentiate species. Treatment antibiotic will be given based on the sensitivity. Next is Yersinia. Yersinia pestis, it give rise to plague, which is bubonic and pneumonic. Enterocolitica and pseudotuberculosis give rise to enteric infections. Virulence, F1 antigen, plasminogen activator, and K3SS. Laboratory diagnosis include culture, serology. Treatment, drug of choice will be given, which is streptomycin, tetracycline. Transmission is through zoonotic, flea, which is plague, contaminated food or water. Next is Pseudomonas aeruginosa. Again, it is opportunistic, gram negative, oxidase positive, and motile. Infections shows pneumonia, UTI infection, wound infection, otitis externa. Virulence is exotoxin A, elastase, biofilm production, and thiocyanine production. Laboratory diagnosis include oxidase positive, pigment production, grape-like odor. Treatment will be given piperacillin, tazobactam, cephalosporins, aminoglycosides. Infection control is important. Next is Vibrio. It is curved gram-negative rods. It is motile in shape, halophilic in nature. Vibrio cholera, it is massive watery diarrhea via cholera toxin. Other vibrios show parahemolyticus, which is seafood, gastroenteritis, and vulnificus, which is wound and septicemia. Laboratory diagnosis include TCBS agar, oxidase positive. Treatment will be given rehydration plus antibiotics. Prevention is safe water sanitization and oral vaccine. Next is Helicobacter pylori. It is curved gram-negative rod, urease positive, microaerophilic in nature. It causes chronic gastritis, peptic ulcers, gastric cancer. Virulence is urease, flagella, this CAGAVACA genes, resins. Laboratory diagnosis include urea, breath test, stool antigen, biopsy, which is a rapid urease threat. This treatment include triple or quadruple therapy with antibiotics. Next is Campylobacter. It is curved gram-negative rods, microaerophilic and motile in nature. It causes gastroenteritis, which is bloody diarrhea, abdominal cramps, and this Guillain-Barré syndrome. Reservoir is poultry or cattle animals. Laboratory diagnosis includes stool culture on selective media, microaerophilic incubation. Treatment will be given usually self-limiting time. Severe cases will be given fluoroquinones and macrolides. Aeromonas, it is gram-negative, rod-shaped in nature, fresh water and soil. It causes gastroenteritis, wound infection, septicemia in immunocompromised patient. Laboratory diagnosis, oxidase positive, it grows on McConkey agar. Culture and biochemical test will be done. Treatment, supportive or antibiotics will be given. So for summary for this whole PPT, lactose fermentation differentiate enterobacteria species. Oxidase positive non-fermenters include Pseudomonas species, Vibrio and Aeromonas. Opportunistic versus primary pathogens. Antibiotic resistance is a major concern, sensitivity which will result to for sensitivity testing essential. Prevention is must hygiene, sanitation and vaccination wherever it is applicable. Infection control. Question for 3 mark. First, name two lactose fermenting enterobacteria species. Second, what is the characteristic sputum in Klebsiella pneumonia? Third, mention one virulence factor of Shigella. Fourth, give one reservoir of Salmonella. Fifth, name two virulence factors of Yersinia pestis. Sixth, what is the characteristic odor of Pseudomonas aeruginosa? Seventh, name the selective medium for Vibrio species. Eighth, mention one test for pyroli eradication confirmation. Ninth, reservoir of Campylobacter jejuni. 10th, why does protease cause urinary stone? For 5 mark question, first discuss laboratory diagnosis and clinical features of typhoid fever. Second, describe pathogenesis and clinical features of bacillary dysentery. Third, write short notes on Klebsiella pneumonia. Fourth, discuss pathogenic mechanisms and laboratory diagnosis of protease infectious, include both mirabilis and vulgaris. Fifth, describe bubonic and pneumonic plague and their transmission. Sixth, explain virulence factors and clinical significance of Pseudomonas aeruginosa. 7. Discuss pathogenesis, clinical features, and treatment of cholera. 8. Write short notes on Vibrio vulnificus infections. 9. Discuss pyroli virulence factors and management of peptic ulcer diseases. 10th, describe Campylobacter infection, its clinical features, and laboratory diagnosis. So with this, we'll cover whole gram-negative bacteria in today's class. So, are you there, sir?
Yeah, madam. I'm there. Full class I have listened.
Oh, okay, sir. So with this, we'll wind up
Very nice,
gram-negative
ma'am. Very
bacteria.
nice. Yeah, we will end this class.
Okay, sir. Thank you,
Thank
sir.
you, madam. Thank you so much. I think
Thank you.
today is the 9/11, I think, time. Okay.
Oh,
Okay.
no issues, sir.
Thank you,
All
madam.
right, sir. Thank you.
Okay.